Alright guys, it's Diagnosing. I'll be doing a presentation on the shoulder joint, diagnosing, a little bit of treatment. First thing I do when I see the patient is ask where the pain is. We're gonna go through that step by step, and then the next thing I'm gonna do is check the range of motion. So raise your arm forward. There we go. Down. Compared to the unaffected arm. And down. Okay. Touch the scapula behind the back. Okay. Bring it down. The other arm. Perfect. Bring it down. Turn around. Hand behind the back. Touch the opposite scapula. You guys can start seeing the internal rotation. Relax. The other arm. There you go. So in my last video, I spoke about in unstable types that are a little more hyperflexible and the tight one. We already know which one Russell is. Alright, so like I said in the other video, there is a hyperflexible, unstable type. We can all agree Russell is the tight, is limited in internal external rotation, a little bit in flexion. So I'm gonna show some landmarks how I would approach this type of shoulder pain and assess him as if it were the first time that I was seeing him. So this that you guys are seeing are not actually his tattoos. I just marked some, just made some landmarks just to show. When I isolate the short head, for example, this is gonna move because it's right on the skin, but I'm gonna show with the arm like that in neutral. So I said in another talk that anterior shoulder pain is mostly caused by the short and the long head of the biceps. So you can find a little bony structure here called coracoid process. That's the proximal insertion or the origin of the short head of the biceps. When patients have pain in this area, it usually radiates down through the tendon. You can find right on the coracoid process. It can be painful, and down following the tendon, the short head of the biceps. Here, there's a little rim, little structure above the glenoid called supraglenoidal tubercle. That's where the long head of the biceps is. If Russell holds his arm up a little bit, you can feel right here in the division of the deltoids there is a little sulcus. Okay, so the humerus has two bony structures, the greater tubercle and the lesser tubercle. The long head of the biceps sits right in this groove. It's the main source of clicking in the shoulder. When people raise their arms, the long head of the biceps can click sideways because it flips side to side on the bicipital groove. Okay, that can cause inflammation and pain, or not. It can be inoffensive and not give you problems whatsoever. The clicking is not worrisome. So short head of the biceps, you come to the long head, palpate the long head. Find the long head. It's a little indentation in between the anterior and the mid deltoid. Palpate all the way down. You can use your thumb, you can use the tip of the index and the mid finger. Okay, if there's pain to palpation, typically it'll go down the whole trajectory of the tendon. The belly of the muscle start a little lower here, so all this is just connective tissue. Tendon, rich in collagen type 1, it's a hard structure. You can turn the arm in external internal rotation, and sometimes you feel a little clicking underneath your fingers. That's another way of finding it. You know you're on the long head of the biceps. Here it's highlighted the subacromial bursa. Now there's a lot of special tests for the subacromial bursa, shoulder impingement, and I've done it hundreds of times and did not get a positive for the test. To me, what does not fail is palpation. I'm big into palpation. You know, in my videos I try to isolate the landmarks, muscle, tendons, bony parts, and explain, because that's how surgeons find the anatomical spots to make an incision for surgery. They palpate before, that's how they get in. That's how they know they are cutting through without lacerating a nerve. So it's very, very, very important, and it's extremely accurate. I'm big into palpatory anatomy. So subacromial bursa, that you can see I marked the end of his clavicle. You can follow here, the clavicle ends here, and it's also the end, this marks the AC joint, acromioclavicular joint. So the acromion bone comes, it's actually the end of the spine of the scapula. Okay, so the spine of the scapula comes here from the back, and it ends as a bony structure that can hook a little forward. Okay, there are 3 types of acromion: type 1, type 2 hooking a little down, and type 3 that is completely hooking down and curved. Type 3 acromions can suffer a lot of impact against the greater tubercle, which causes an electricity called piezoelectric force to increase that attracts calcium, and some little bony fragments start forming called spurs. So typically type 3 acromion requires surgery, you know, for some shaving. The outcomes of physical therapy are not very good because it's an anatomical dysfunction, you know, and it doesn't change. You can do as much flexibility, strengthening as you want, and you know, the type 3 acromion will still be there. It'll still be hooking down, and it decreases significantly the space for that the head of the humerus has, you know, to glide and twist and accommodate the greater tubercle when the patient is doing overhead activities. Okay, so more posterior to the long head of the biceps. So short head, long head. I marked a little bit of the rim of the glenoid, or the end more or less of the greater tubercle. They are right here. And or when you see the uppermost top rim part of the shoulder, this very rim that you see, that's the end of the glenoid, and you can palpate the beginning of the greater tubercle. That's where the supraspinatus tendon is. Supraspinatus comes from the suprascapular fossa, crosses from underneath the coracoacromial ligament, and inserts on the greater tubercle. It's also a site of shoulder impingement. It has a lot of impact. In close packed position, this tendon is pinched against the acromial bone, against the coracoacromial ligament. So remember, here's the acromion, here's the coracoid, there's a little ligament right here. Okay, the long head of the biceps, as well, the supraspinatus tendon can be pinched against the coracoacromial ligament and the acromial bone. So if you palpate positive for supraspinatus tendonitis, you get a little bit of the bursa, like I'm showing here, especially when it's swollen. A little bit of bursitis. They usually come together, tendonitis, bursitis, and it's hard to differentiate one from another just by palpating or assessing the patient. You come a little more posterior, and you're not really going all the way to the posterior shoulder. You're just coming to the posterior rim of the greater tubercle. Okay, so posterior shoulder is more muscular. The greater tubercle is right here. So you go from superior rim to posterior rim. Of the greater tubercle. So palpation, pain to palpation on the posterior rim of the greater tubercle could mean tendonitis of the external rotators. Both the infraspinatus and the teres minor insert on the posterior rim of the greater tubercle. Okay, You can palpate the upper traps. They can sometimes radiate pain down the shoulder. Check the scapula. There are lots of trigger points on the posterior scapula. Just to make sure, check the scapular range of motion. I said on the video about stability. You guys may want to review that. The scapula has to wing. When the scapula wings, it opens space. This whole shoulder, the whole complex open space, and the rim will go from pointing laterally to pointing a little more superiorly. So it does like this, and it cups up. It opens space for the head of the humerus to glide and keep going up. Okay, so you have to check for scapular mobility. So when all palpation fails, so the pain is not palpable, the pain comes from inside, number one. Throbbing pain, number two. Pain that is worse at night or early in the morning. These are all signs of labrum tear. Okay, labrum tear is typically traumatic. So from a fall, it could be an outstretched arm, it could be a fall straight on the shoulder. It can happen different ways. But typically, if the pain is not palpable and other structures can be irritated because of the inflammation, you don't necessarily find intracapsular swelling, especially in muscular types like Raciel. But there is that typical sign. You don't find any structures that really reproduce the pain. It fails manual muscle test. It fails the palpatory, and is the typical night pain, morning pain, and more important than all of them, any clunk in the joint. So typically when the patient is raising the arm overhead, that may feel a little clunk, or doing internal external rotation. You know, sometimes they're trying to wash their back or doing something on the opposite shoulder and they feel a clunk inside of the shoulder. So there are several special tests for impingement, tendonitis, instability. I'm not gonna go through each one of them. What I'm offering is, like I said, I'm big into palpation. That's what I wanted to show. But I definitely have to show a little bit of how I assess the labrum. I don't believe in special tests like it has to be like that, it has to be 90 degrees. It's not, biomechanics is not that mathematical, it's not that precise, in the sense that you can do a crank test, for example, just putting pressure, you put pressure against the glenoid and you do internal external rotation to see if you feel any clunk, right? So what I like to do is change the angles. I'll play in different angles and I'll use more power. Typically students are a little afraid and they'll put very little pressure, do like this, and they're like, no, clunk is the crank test is negative. And that's incorrect, okay? Sometimes, you know, right after they touch the patient, I go and I do my thing and I play around, because to me, I don't care how crank or whatever doctor described the test, I can go and I play and I try to find some clunk in the labrum. Okay, so that's something that I wanted to clarify. To me, the anterior apprehension test is of extremely value, because the patient will not let you bring the arm in external rotation. They will hold back the arm. That's a sign of slab tear, anterior labrum tear, superior anterior to be more precise. And with the posterior labrum, I also play with a straight down caudal pressure, or even bringing across in horizontal adduction and putting some pressure, forcing the head of the humerus a little more outwards, posterior and lateral. And you can also do the movement like in the crank test to see if you feel any clunk, pinching pain. Typically, the posterior labrum, you know, when you press down, the patient will refer some pain on the posterior shoulder. With the anterior apprehension, they will feel kind of inside, it's kind of a diffuse pain. Okay.